Why did this 43-year-old lady suffer a stroke while on a trip to Manali? Welcome to another episode of Stroke Rounds. A 43-year-old lady who suffered a stroke while on a trip to Manali. While enjoying her vacation, she suddenly developed shortness of breath and was taken to a nearby hospital. Based on her ECG and biomarkers, she was suspected to have a non-ST elevation myocardial infarction. She was referred to Delhi, the nearest center with advanced facilities. However, the very next day, she developed seizures and vomiting. A CT scan of the brain at that time was normal. A CT pulmonary angiogram revealed filling defects in both right and left segmental pulmonary arteries, suggestive of pulmonary embolism. Since she did not have close support or relatives in Delhi, they decided to shift to Kerala for further evaluation and treatment. Now let's take a closer look at her risk factors. She was using oral contraceptive pills and has a history of bipolar disorder. On arrival here, she was conscious but had signs of brainstem dysfunction. These included internuclear ophthalmoplegia, bilateral nystagmus, facial palsy, and significant cerebellar ataxia. Motor power was preserved. An MRI of the brain revealed diffusion restriction in the pons and the left superior cerebellum. MR angiography showed an occlusion at the top of the basilar artery. Let's pause here to understand the types of basilar artery occlusion. Proximal and mid-basilar occlusions are often linked with atherosclerosis. Top of basilar occlusion, on the other hand, is more commonly embolic, caused by a migrating thrombus. She underwent a cerebral angiogram, which confirmed occlusion at the top of the basilar artery. A microcatheter was carefully navigated across the clot and positioned distal to the occlusion. The proximal basilar artery appeared normal. Given the risk of imminent deterioration, the option of mechanical thrombectomy was discussed and initiated. An aspiration catheter was guided up to the mid-basilar segment. A stent retriever was deployed across the clot. The red arrow shows the struts of the stent retriever. The blue arrow shows the tip of the aspiration catheter. And the yellow arrow indicates the junction marker between the wire and the stent retriever. On the first pass, the clot was successfully retrieved and complete vessel recanalization was achieved. This was the thrombus removed from the basilar artery. Further workup with echocardiography showed mildly dilated right atrium and ventricle, concentric RV hypertrophy, and moderate pulmonary artery hypertension. No regional wall motion abnormalities were seen, and left ventricular systolic function was preserved. There was also mild tricuspid and pulmonary regurgitation. CT pulmonary angiogram showed thrombi in both pulmonary arteries. Sagittal view showed a large thrombus was visualized in the left pulmonary trunk. A venous Doppler of the lower limbs showed echogenicity in the right tibial vein, suggestive of deep vein thrombosis. To complete the evaluation, a transcranial Doppler with bubble study was done, which showed multiple microbubbles, confirming the presence of a patent foramen oval, or PFO. So what were the risk factors in this case? Use of oral contraceptive pills, prolonged air travel, high-altitude hypoxia, underlying DVT, and a PFO facilitating paradoxical embolism. The key takeaways from this case are: mechanical thrombectomy can still be beneficial even beyond the conventional time window. Always rule out DVT and PFO in cases of systemic embolism, especially when no obvious cause is found. Thank you for watching Stroke Rounds. Please share your thoughts and comments below. See you next time with another interesting stroke case. Disclaimer: voiceover is AI generated.